Morning, afternoon, and evening to everyone who is here and virtually joining us on our second day of GEEF 2024. Welcome back, and I am Jung-Gil Ko, an associate professor in the College of Computing here at Yonsei University. At Baekhyang Hall, Grand Ballroom A, we will start our day with a very special session that will discuss about the impact of the global burden disease study on achieving the SDGs. This session will be moderated by Professor Jae Shin from the Yonsei University College of Medicine. Professor Shin, the floor is yours.
Good morning. Welcome for joining this great session. It's my honor to moderate this session. I would like to introduce the speakers and panelists today in this session. So, Professor Mohsen Nagavi, he is the director of IHME's Subnational Burden of Disease Estimation, IHME, at the University of Washington, and Professor Laura Dwyer-Lindgren, Assistant Professor, Health Metrics Science, IHME at the University of Washington, and Professor Jamila Mahmood. She is Executive Director, Sunway Center for Planetary Health, Sunway University, Malaysia, and Professor Jalim Zhou. She is Assistant Professor, Yonsei University of College of Medicine. So, global burden of disease is led by IHME, which is founded in Seattle, also by the core grant of Bill and Melinda Gates Foundation, and leading the epidemiologic estimates of global burden in the world. So this session is to introduce global burden of disease and also the Anthropocene, the recent problem, and the disease burden later. So the first speaker will be Professor Mohsen Nagavi. So he is doing many researches in subnational burden. So because the disease estimates and disease burden will be different even in one country. So Professor Mohsen, please.
Thank you so much. Thank you. Good morning, everybody. My name is Mohsen, and I am professor of the Health Metric Science in University of Washington, and I am very happy that again talking with the friends and colleagues in the Republic of Korea. 2-3 months ago, I was in Korea, and then I had some discussion, and again, I will have some discussion. My suggestion is that anytime that you have question, you can interrupt me and ask your question. Otherwise, in the end, we can answer all the questions. Okay. First, let's see IHME, what is the Institute of Health Metric and Evaluation or in other name, IHME. IHME started in 2007 based on the all of knowledge about the summary measure in the world and global burden of disease that happened before 2007 in WHO, in World Bank, and in Harvard University. We started under the leading of the University of Washington. In other words, we are some part of University of Washington and also supported by the Bill Melinda Gates. We have many partner institutes, lots of partner institutes. Some of them are in Korea, some of them is in Europe, some of them in Asia. And most important thing that in the past, before 2007, everything that happened in the GBD, it was 2, 3, 10, 20% that doing this job. Now it is our institute with more than 10,000, 11,000 collaborators in the many parts of the world. And you can see that in South Korea, in Korean Republic, we have 170 collaborators that helping us for the estimation. In other words, GBD is not some local work. GBD is an international work. Now we have, this is some specification about IHME. We have 466 person in IHME, 31 faculty, 181 paper in 2022, and something in the 200,000 citation in 1 year, and many, many details that I don't want to go through that. And let's say in the global burden of disease, what we are doing in global burden of disease, we calculate 371 disease burden. But when we want to calculate disease burden, we have to divide them to the sequela. Sequela is outcome of the any different outcome of the any disease, and it is, and also we calculate 87 risk factor for the 204 country and 22 subnational estimation. For example, in your neighborhood, we calculate Philippines by subnational, we calculate Indonesia by subnational, China, Japan, Russia, US, UK, Poland, many countries, we calculate by subnational. In other words, every time that we run GBD, we run GBD for the 900 location or 900 country. In addition of the GBD, we have many other things in the GBD, same as financing, same as local and small area estimation, future health scenario, burden of antimicrobial resistance, and US health disparity that Professor Laura will talk about that. I will talk about GBD. Okay, what is the GBD? Think about this, that we gathered all of the available data, all available data in the systematic way. And then we will put together this data in the scientific way. And then we calculate health gap for the different disease, injuries, and different cause of health loss. In other words, GBD is a complex of all the available data, adding together in the scientific way, in the collaboration with the international collaborator in the world. Okay. How we calculate, I don't want to go through all the details, but there is 4 components in the burden of disease. First, we want to calculate burden of disease for Republic of Korea. First, we calculate what is the population in Korea by age, by sex, by year. What is the number of deaths in this population? All-cause mortality by age, by sex, by year. And then what is the number of the deaths by cause in the different causes in this population, in this mortality. First, we calculate population. Second, we calculate number of deaths as an envelope. Third, we calculate different deaths due to the different causes. And then we will go to the calculation of non-fatal based on the getting some help from the mortality and including all other data sources, including hospital data, claims data, and then we calculate risk factor, that what is the causes of these diseases. This is not correct, that just we show that what is the problem. We are trying to answer many questions. What is the cause of this problem? And based on that, we calculate that by these causes, how many years we lost due to the premature deaths or due to the disability. Okay, now let's go to the Korea. This is age standardized death rate in Korea. You can see from 929 decreased until 362. Okay, you did very well. And if you look, never number of the deaths, age standardized mortality rate difference between 2 years were positive. All the time were negative, except of the 2020 to 2021, that is increasing due to the COVID. Okay. This is now look to the COVID. I compared COVID deaths between Korea and Japan. And you can see Hokkaido was worse than you. And also Brunei Darussalam was worse than you, but Singapore was better than you. But in 2021, you were bad. Bad means that you had a lot of deaths in comparison with the Japan that is here. Hokkaido now is better than you, but anyway, you are same as Brunei Darussalam. Okay, now let's go and talk a little about the before COVID and after COVID, what happened. This is number of the deaths in 1990, top 20 causes. 1990, your top 20 causes was stroke, ischemic heart disease, stomach cancer, cirrhosis, going down. And in 2019, this number, these causes change to the stroke, Alzheimer, ischemic heart disease, lung cancer, lower respiratory. Did you see that? That stomach cancer going down, you had very good prevention, but self-harm going up. And then after that, this is 2021, you can see that stroke, Alzheimer, lung cancer, self-harm, lower respiratory, liver cancer, and then COVID. Okay, now let's look in this way that, okay, what did you do from 1990? What different government did in your country? Okay. From 1990 until 2021, you increased your life expectancy 11.7 years. That is great. There is no same as this in your region. Singapore is 10 years, Japan is 6 years, Brunei Darussalam is 5 years. And you can see that biggest causes that with the prevention and with the treatment, good treatment and good prevention, you decreased was stroke and the neoplasm and ischemic heart disease and the transport road injury, and then go to the enteric disease. Perfect. You increased a lot your life expectancy, but you lost your life expectancy a little, not a lot, due to the COVID. 0.3 year you lost due to the COVID. Some country lost 4 years. You lost a little, but some country like Japan lost lower than you, and China lost lower than Japan and your country. Then, anyway, there is some distribution. Okay, but we do not look just to the deaths and death number, because usually if we look to the number of the deaths, just all the deaths that happened in the old age, it will go to the top. Then we calculate mortality based on the how many years we lost due to the premature deaths. Then we calculate these with the comparison with the standardized life table. How we calculate a standardized life table? We calculate a standardized life table based on the lowest age-specific mortality rate in the world. Then we this is your life expectancy. Again, you can see this is your life expectancy. You started from 72 and now you are in the 82. Japan started from 76, now they are in the 86. You increased more than Japan, but didn't ask the Japan. And you can see in here, in comparison, in the all area, you are here better than some state in Japan, some prefecture from Japan. But anyway, this is the process that we have. Now let's look to here. Okay, let me move this here. Okay, this is number of the deaths in 2019. Ranked number of deaths in South Korea in 2019. Now we sort this based on the how many years that we lose due to the deaths. It means that any deaths that happen in the younger age will go up. Then your top killer that lose your life expectancy, your life that you have in your country, first is self-harm, suicide. Second, lung cancer, ischemic heart disease, stroke, stomach cancer. Stomach cancer kill the people in the young ages, and also lung cancer. Lung cancer doesn't make difference, but anyway, you can see some causes going up: colorectal cancer, liver cancer, cirrhosis due to the alcohol, breast cancer is going up due to the killing people in the young ages. Okay, and if you want to compare these three countries, that here is Japan, first one, second one is Korea, third one is Singapore, your suicide doesn't make a statistically difference with the Japan, but statistically is much higher than Singapore. Lung cancer, you can see number in the Japan statistically higher than you, and Singapore is lower than you, and go to the all other causes. And look to the COVID. Your COVID, this is 2021, your COVID was higher than Japan, but statistically is same as Singapore. Okay, now you saw that we looked to the number of deaths in your country, we looked to the life expectancy, we looked to this, that how many deaths, how many years by the each deaths, how many years do you lose due to the premature deaths. Now look to the something with the name of the disability. Okay, this is a kid, and you can see it. Sometimes he was sick. For example, here he had diarrhea, here he had road traffic accident, here he had one other problem, here he had diabetes, and then we put together all of these diseases based on the disability, duration of the disability that this person had. In other words, we calculate something with the name of the VLD. VLD is result of prevalence multiplied on the disability rate. I do not have time to go through the all detail. Just you should get something about overall from everything that I am saying. And by the end, YLL that I explained, YLD that now I explained, we put together YLL and YLD and calculate DALYs. DALYs, it means how many years we lost due to the premature deaths and due to the disability. Here is something that for the disability rate that we gathered based on the population-based survey in 2011, and this is some weight between 0 to 1. That 0 is very, very low disability, and 1 is 100% deaths. And okay, this is, and we published. If you want, in Lancet 2012, the paper with the first author is Joshua Solomon. You can read and you can see what is the disability rate. Anyway, let's come back to Korea. Again, here was Korea, number of the deaths, ischemic heart disease, lung cancer, ischemic stroke, blah, blah. This is based on the VLL, how many years we calculate, self-harm, lung cancer, ischemic heart disease, ischemic stroke. This is based on how many years we lose due to the disability. Top one is low back pain. Second one is other musculoskeletal, diabetes, age-related hearing loss, fall, migraine, and this is the final thing that you should look. Your problem in health problem in Korea is low back pain. This is 2019, sorry. Low back pain, diabetes, self-harm, and other musculoskeletal, lung cancer, and going down. Okay, and if you look to the comparison between these three countries, there is no difference between these countries statistically, but there is difference for the self-harm, there is difference for the other musculoskeletal, there is not difference, there is not big difference for the diabetes, but anyway, ischemic heart disease, you can see, is much, much higher in the Singapore, and your number is same as Japan, and same as this for the lung cancer. Okay, then in addition of the YLL, YLD DALYs that we calculate how many percent of the each DALY can be due to the different risk factor. or how many percent of the deaths in liver cancer we can assign to the alcohol? How many percent of the lung cancer in South Korea we can assign to the tobacco? This is attributed values that we calculate based on the risk factor. For this, conceptually is very easy. We calculate prevalence of the risk factor, multiply on the relative risk of the having lung cancer due to the due to the tobacco, or some other thing like ischemic heart disease due to the hypertension. Then we do this process. And here is your situation. This is in 2019. This is in 1990. This is in 2019. Your top risk factor was blood pressure. You decrease this very well with the control of your health system. You are doing a very good job for the checking hypertension in the people, blood pressure, and treat them and control them. But alcohol and tobacco went up because your control is not good or is not possible. I don't want to say that, okay, it's not, you are weak. No, it is very hard to control behavioral risk factor. And third one is high blood glucose that you can see here, and blood pressure, BMI, that you can see. These three problem is coming to your country: smoking, alcohol, and glucose, blood glucose. And then look here, if we sort again country based on the highest burden due to the risk factor, we see that South Korea, same as Japan, has a big, highest risk factor that kill your people is smoking, much higher than Singapore. But alcohol is just for you. Japanese and Singaporean drink alcohol lower than you. Then, in other words, alcohol and tobacco is the big problem in Republic of Korea, and you have to control that in any way. After that is high fasting blood glucose, hypertension, particulate matter, air pollution, high body mass index, and other. But if sometimes your minister asks you, okay, what I have to do? Answer is very clear: tobacco, alcohol, and high fasting blood glucose. These are three important interventions. If minister wanted more detail, you can go through the GBT Compare in the online that is accessible for everybody in the internet, and show to him that what he has to do. Thank you so much. I hope that if there is any question, I can answer all of your questions and use your comment in our future work. Thank you so much.
Thank you so much. Your nice presentation on the what is global burden of disease and the changes of disease burden during the 30 years in South Korea. We'll discuss later at the end of our session together Okay, so next presentation speaker is Laura Dwyer Lindgren. So she will talk on the this burden in United States. Laura, please.
Thank you. I'm really excited to be speaking with all of you this morning. Thank you very much to the organizers for the invitation, and also to Professor Mohsen for setting up a lot of this talk. So I'm going to be talking about one particular part of the GBD, one of the many parts that Professor Mohsen had mentioned, specifically focusing on US health disparities. So this is part of a broader project, and the goal of this US Health Disparities Project is to estimate the burden of disease and health disparities in the US at the county level and stratified by racial and ethnic group. And it uses the same overall framework and conceptual approach as the GBD. So many of the things that Professor Mohsen had just mentioned. So we're focusing on all aspects of health loss that includes fatal health loss and non-fatal health loss and risks. We're looking at a lot of different metrics, so not just deaths, but also years of life lost, not just incidence and prevalence, but also YLDs. We're considering quite a wide range of health conditions, not everything that the GBD considers, but a pretty substantial fraction, and based on the list of causes that the GBD considers, and similarly with risk factors. And this particular project and part of the GBD is a collaboration between IHME and the National Institute on Minority Health and Health Disparities, or NIMHD, which is part of the US National Institutes of Health. Specifically today, I'm going to focus on just one of those major components from the GBD. So this corresponds roughly to the first two boxes in the key component slide from Mohsen's presentation. And so this will be talking about fatal disease burden and looking primarily at life expectancy and cause-specific mortality in the US. And to give you a slightly better idea of the dimensions of the analysis in this particular case, we're doing this analysis at the county level. That's what the map on this slide shows. There are approximately 3,100 counties in the United States. We are stratifying this analysis by race and ethnicity. If you're not familiar, these are, properly speaking, two different concepts. So ethnicity in the US refers to whether or not somebody has Hispanic or Latino ethnicity. And then race refers to if they are white, Black, Asian, Pacific Islander, or American Indian or Alaska Native. We combine those things. So anybody who has Hispanic or Latino ethnicity, regardless of their race, is in the Latino group in our analysis. And then people who are not Hispanic or Latino are in one of four other groups. We combine the Asian and Pacific Islander group for some technical reasons, but that group is nearly all Asians. And so we refer to that group as Asian since the estimates primarily represent that group. So we have these 5 racial and ethnic groups. We have 20 years in the analysis currently, so it's from 2000 to 2019. We are presently working on expanding this to the COVID era, but for the moment I'll be focusing on pre-COVID. And for causes of death, we considered 176 causes of death. One thing I want to just stop and explain at this point is a little bit of motivation about why we're doing this at the county level and why we're doing this by race and ethnicity. So the US is a big place, 300-odd million people living here, and there's a lot of variation in health outcomes within the US. And you can see that at the state level, and the GBD, the main GBD, I should say, estimates at the state level, and you see really substantial differences at the state level. And work that we have done previously and that others have done previously shows that even within states, there's a huge amount of variation among counties, which is the next level down. So that's really the motivation for looking at this at the county level. If you only have one number for the entire US population, you're probably missing quite a bit of variation. And then in terms of race and ethnicity, for historical reasons related to colonialism and the history of slavery, and for contemporary reasons related to people's experience of racism, there are very, very large disparities in health outcomes between the 5 groups that I've listed here. And plausibly, the size of those disparities varies, again, spatially. And so crossing here and looking at this at the county level and at the same time by race and ethnicity, we think is worthwhile to study sort of the intersection between place-based disparities and racial and ethnic disparities. I'm not going to talk a ton about methods, but I do want to describe the data sources that we used for this part of the analysis, so you have a sense of sort of where this is originating from. So sort of the two key things if you want to estimate any measure of fatal health loss are deaths and population. So the deaths data comes from death certificates. There is something called the National Vital Statistics System in the US that's essentially a collaborative process among all the different states and ultimately results in a compilation of all death certificates for people who die within the US. And then you also need to know the population, which gives you sort of the denominator when calculating mortality rates. And we are lucky to be able to use population estimates at the county level directly from the US Census Bureau and from the National Center for Health Statistics. Our statistical models also use a few other pieces of information in the form of covariates. This is sort of your typical sociodemographic variables, things like the poverty rate, income, educational attainment, and so on. This comes from a lot of different sources, but the big ones are from the US Decennial Census and then something called the American Community Survey, which is an annual 1% sample of the US population. And then this is really specific to this analysis, but when race and ethnicity are recorded on death certificates in the United States, they're recorded by somebody else since you cannot self-report on your death certificate, and sometimes they're reported incorrectly. And that creates a disconnect between the population estimates and the death estimates. And so these misclassification ratios that we're borrowing from a previous publication are a mechanism for correcting for that disconnect. So I'm going to give you kind of a sample of the results from this analysis so far, starting with life expectancy. So the plot here shows estimates at the national level of life expectancy from 2000 to 2019. And if you look at the gray line with the upward facing triangles, that shows the overall trend in life expectancy in the US over this period. And then each of the other lines shows the trend in life expectancy for each one of these 5 racial and ethnic groups. So life expectancy in the US is relatively high on a global scale. However, progress in terms of improving life expectancy in the US has been extremely lackluster for a few decades now. And you got to keep in mind too that this is before COVID. Things obviously got worse in the last few years. But you can see if you look at the gray line that there was a little bit of an increase in life expectancy between 2000 and 2010, but then it basically just leveled out between 2010 and 2019. And then when you look at the lines for all of the other racial and ethnic groups, you'll see that the difference in life expectancy, both at the beginning of the period and at the end of the period, are very, very large. So compared to the total population, the life expectancy in the white population is pretty similar, which makes sense because the white population is the majority group. But life expectancy in the Black population is substantially less, several years less. But life expectancy in the American Indian Alaska Native population, which is abbreviated as AIAN here, even less than in the Black population. And then conversely, life expectancy among Latino people and among Asian people in the US is quite a bit higher, both than the overall average and then also for the white population. You can see too that the trends have been a little bit different over time. So some of these gaps between different groups have changed in magnitude over time. Now, it's tricky to show that same kind of view, but at the county level at the same time. So I'm switching to a map view. And now I'm showing just life expectancy in 2019. So nothing about change, but just about sort of a snapshot of the disparities, both across location as well as across racial and ethnic group at the same time. So kind of the key things to note here is that if you look at the color scale, the reds and the oranges are places and populations where life expectancy was typically lower. And then the greens and blues are places and populations where life expectancy was typically higher. And on average, you see comparing across the maps, which show the different racial and ethnic groups, the same kind of gaps that you saw in the previous slide. So for example, there's much more orange and red in the map for the Black population, for the AIM population, and there's much more blue and green, particularly in the map for the Asian population. However, the other thing that you'll notice, on all of these maps is that there is a lot of variation among counties, and that's true even when you limit to one single racial and ethnic group. So if you look in the bottom right, that shows just the estimates for the total population in each county. You can see there's a multi-decade difference in life expectancy, depending on where you're sitting. And that's also true within just the white population or within just the Latino population and so on. This slide has the same layout as the previous one, but now it's looking at the change in life expectancy over the period from 2000 to 2019. And anywhere on this map that is in blue or green is a population and a location where life expectancy increased, and anywhere that's in pink and purple is a decrease in life expectancy. And so you can see here that for some populations, let's say for the Black population, life expectancy increased pretty much everywhere in the US over this period, which is a good thing. But the size of those increases were really variable. So you have places where the increases were, a decade or more, and then places where the increases were much more moderate. In contrast, if you look at the map for the white population, or particularly for the Latino or AIM population, there's actually quite a few places where life expectancy decreased over this period. And again, you have to remember this is before COVID. So the fact that life expectancy decreased, and in some cases decreased by quite a lot, is really rather remarkable. The other way to view this is to think about what the racial and ethnic disparity is within a county. So we do this by comparing primarily to the white population. That's again because the white population is the largest numerically, and so it's the one where we can have kind of the most stable set of comparisons. And you can see from these maps, now anywhere that's in purple is a place where life expectancy is higher compared to the white population living in the same county. So for the Asian population, which is the map in the upper right, life expectancy is higher compared to the white population almost everywhere outside of the state of Hawaii. And for the Latino population, something similar is true. Life expectancy for the Latino population is higher in most places, but there's actually a big chunk of counties in the American Southwest and in Texas and again in Hawaii where the reverse is true. And then conversely, for the American Indian, Alaska Native, and the Black population, you'll see that most counties follow the national trend, which is lower life expectancy for these groups compared to the white population. But there are some exceptions, and there's also, again, a huge amount of variability in the actual size of the disparities. So there's places where these disparities still exist, but are much smaller, and there's places where these disparities are actually much larger than what you see nationally. And then moving on from life expectancy, I want to talk a little bit about cause-specific mortality. So moving into the second sort of key box from Professor Mosen's slides. So the layout here is again going back to looking first at the national trends. This is national trends in age standardized mortality. And the upper left panel shows all-cause mortality. So this is essentially just the reverse of what we saw for life expectancy. And then each of the subsequent panels is for a different cause of death. This is from level 2 of the GBD cause hierarchies. These are kind of larger groupings of different causes of death. And the different colors, again, indicate different racial and ethnic groups. So if you look at life expectancy, you see, again, just the reverse of the pattern that we saw for, if you look at all-cause mortality, you see the reverse of the pattern we saw for life expectancy, where now the Black and the American Indian population have the highest mortality. The Latino and the Asian population have the lowest mortality. The white population is somewhat intermediate. And you can see if you look across different causes that there's frequently a similar ordering. Sometimes the Black population and the American Indian population swap, occasionally the Asian population and the Latino population swap, but usually there's sort of this discrepancy and it follows a somewhat similar pattern. There's a handful of causes where there are exceptions. So for example, for chronic respiratory diseases, the white population has substantially higher mortality than the Black population, likely as a result of differences in tobacco use. And then there's some causes where just one group is at such an extreme disadvantage compared to other groups. So you can see that, for example, for HIV, where mortality for the Black population is just so much higher than it is for any other population. And you can see something similar for the AIN population, for example, for digestive diseases as well as for transport injuries. But a lot of different variations to some extent on the same theme, but particular stuff going on for each cause of death. This is the same layout, so we still have all-cause mortality in the upper left corner, and then all of the level 2 causes sort of arrayed out after that, but now focusing on the disparities that are based on place. And so here what the map shows is the rate ratio. So it's the county mortality rate divided by the national mortality rate for the same cause. And this puts everything on the same scale. So any part of the map where you see an orange color, that is a county where for that particular cause mortality is higher than the national level, and increasingly so as you get into the darker oranges and browns. And then anywhere that's purple is a county where mortality for that particular cause of death is lower than the national mortality rate. So again, if I can draw your attention to the upper left, where we're looking at all-cause mortality, sort of similar to what I was describing for racial and ethnic disparities, there is sort of a general pattern. So for example, mortality tends to be elevated in a big chunk of the southeastern part of the US and in certain parts of the West as well. And then tends to be lower in the North and the Northeast in certain parts of the West. And you see a somewhat similar spatial pattern for a lot of causes. So neoplasms is very similar, cardiovascular diseases is very similar. You know, a lot of others are sort of partially similar. Diabetes is a good example of that. But then you also see some causes that have just dramatically different spatial patterns. So transport injuries is a really good example that has a very, very strong urban-rural gradient. Unintentional injuries is another good example with a really different spatial pattern. And then HIV is an interesting example because it has a somewhat different spatial pattern, but it also has just a massive degree of spatial inequality. So you have these very, very dark purples, which are places where there's very, very little mortality due to HIV. And then you have these quite dark oranges and browns, which are places where there's actually quite a sizable amount of HIV mortality. But again, highlighting that depending on where you live, your experience of what causes people to die is quite different in the US. And also that varies by cause of death, which you know, I think underscores the utility of looking at this by cause. It's quite difficult, as I said before, to look at county and race ethnicity and multiple causes at the same time. So instead of attempting to do that, I'm going to show just one cause, but showing both county and race ethnicity at the same time. And I'm showing HIV because, as I highlighted on the previous two slides, HIV is interesting in that there's a huge amount of disparity between racial and ethnic groups. There's also a huge amount of disparity spatially. And you can see here that that's partly mutually reinforcing. So the Black population, which has the highest mortality rate nationally and also in almost every county, has really extremely high mortality, in particular in Florida and Georgia and other parts of the Southeast. And you can see that that region stands out because it's also a region that other racial and ethnic groups have elevated mortality, although nowhere to near the same extent. I'm going to take the opportunity real quick to point to our visualization tool. It's one of many visualization tools that the GBD has, but this one focuses on US health. It's called the US Health Map, and I've shown the URL there, but if you just Google US Health Map, it should be the first thing that comes up. And this gives you a chance to look at sort of all of the results that we've published thus far from these analyses. You can swap different causes, different ages, different sexes, and so on, and allows you to sort of dig into any particular area that is of interest. So a couple things I want to summarize just from the findings of this analysis thus far. You know, the big thing is that disparities are the norm, not the exception. And I mean that in a couple of different ways. So for every cause of death, we see racial and ethnic disparities. For every cause of death, we see geographic disparities. In every location, we see racial and ethnic disparities. And for every racial and ethnic group, we see place-based disparities. So you really just can't get away from that in the US. There's nothing really even approaching equality for the most part. When you look across different causes of death, there are some common themes that I had highlighted. So mortality is very often highest among the AIN and Black populations. It's very often the lowest among the Asian and Latino populations. There's also certain regions, such as the Southeast and Appalachia, that have relatively high mortality across a pretty wide range of causes. And then you see that reflected in life expectancy values as well. But nonetheless, there's a lot of variations on these themes, and there's also plenty of exceptions, which again underscores the necessity of looking at this, not just in terms of all-cause mortality or life expectancy, but also in terms of causes of death. And then finally, considering location, in our case county, at the same time as race and ethnicity reveals patterns that are not apparent when you're considering location and race ethnicity separately. And so we think that doing it this way and crossing these two features potentially provides the opportunity for new insights, further research, and ultimately we hope for action. So I'll end there and say thank you again for allowing me to speak. I look forward to the remaining presentations and the discussion.
Thank you so much for your wonderful lecture for ethnic disparities in life expectancy and mortality in the United States. Okay, so we'll discuss later. Okay, and the next presentation of mine, could you show the slide? I would like to show some examples of a GBD study in our country, but because Professor Mosen already told us the important changes in our country, I will briefly show the background and situations in South Korea. Yeah, this was recent publication of Lancet Public Health and the population health outcome in South Korea and projections up to 2040. A systematic analysis of GBD study in 2019. South Korea, as you know, the several unique national characteristics. For example, a highly urbanized country. Over 80% of 52 million inhabitants reside in urban area, 50% in Seoul, capital area. And as you know, there was a rapid economic growth. For example, our country was the poorest in the world at the end of Korean War in 1953, but now the 10th highest gross domestic product in the world. In addition, there was a change in health coverage from private voluntary health insurance to government-mandated universal health coverage. So the National Health Insurance Service was founded in 2000, and by 2006, 96% of South Koreans had national health insurance. Only 4 were medical aid. So universal health insurance has improved the healthcare accessibility for all South Koreans. For example, highest number of healthcare-related consultations per citizen, for example, 17 times a year. In OECD countries, mean was 6, so very high. So South Korea is the first for average number of in-person doctor consultation per person. The next is Japan, and the other is European, mostly European countries. So however, the situation of South Korea is funding for national health insurance services expected to decrease due to the reductions in South Korea's working age population. So cumulative reserves will run out soon. So another problem is the increasing burden of non-communicable diseases among older people drives up healthcare cost. So that is the real problem. So to meet this need, detailed analysis of the nation's epidemic risk is important. The previous research demonstrated the burden of disease in Korean population, but detailed analysis has not been done. So the current research was using the global burden of disease study. We estimate the disease burden in South Korea. So we also analyzed the mortality rate attributable to population risk factors and disease burden and male to female ratio, and we forecasted this estimate for leading causes of years of life lost to 2040. So the data was already shown by Professor Mosen already. So age standardized DALI was declined during the past 30 years, and this is the greatest decline in the world. So trends in age standardized deaths and DALI compared to the global, more rapid decline in Korea. So death rate, this was already shown by Professor Mosen, DALI. So I will skip the slides. This is the 30 leading causes of death in South Korea compared to other countries, and death is attributable to relative risk factors in South Korea. So in male, the problem is, the first is tobacco. In females, high systolic blood pressure. So this is the leading 20 causes of age standard years of life loss rate in the 2040 forecast for males in South Korea. And the first is the liver cancer, and the self-harm is the second. So in females, Alzheimer's disease is the first, and the self-harm is still the problem. So summary of our works is showed the landscape of the changes and the disease burden in the Korea. So our research can be used to inform national level policy responses and provide insight for nations sharing similar features with South Korea, because there are many Asian countries shows rapid economic growth, and this may be the example in the future. Okay, so I would like to just share that the health-related SDGs are summarized in this tool is developed by IHME, and this was published in Lancet. You can search this. And if you put your country, you can find health-related SDGs. Thank you for your attention. Okay, the next speaker will be Jamila Mahmood. Okay, she will talk on the Anthropocene, which is the real threat in global health. Okay, Professor Jamila, please.
Thank you very much. Annyeonghaseyo, good morning, everyone. So I'm going to now go the exact opposite direction and really look at big picture data on what are the global health risks in this age of Anthropocene. The Anthropocene is really highly debated right now, but it is basically saying that a lot of the changes that are happening are man-made because of human behaviors. Now, this all came out looking at the planetary health boundaries, which for those who were at my lecture yesterday, that if we know that the health of people is very much dependent on the health of the planet, then what are the boundaries, what are the scientific measurements that one must make or can make to know whether we are in a safe zone? Johan Rockström and his other scientists in 2009 described the planetary boundaries, which has led him to win the Tyler Prize recently. And for those who have Netflix, I really highly recommend watching this documentary called Breaking Boundaries, very beautifully narrated by Sir David Attenborough, which talks in detail about the planetary boundaries in a really nice storytelling, compelling way. But in summary, there are 9 things that ascertain whether we are in a safe zone or not. 8 of them can be directly measured, but 1 of them, there are proxy indicators. Now, if we are going to be in the green, the safe zone, we need to remain in the green and safe zone so that we will be healthy. Unfortunately, as of end of last year, we have crossed 6 out of the 8 measurable planetary boundaries. So this is very, very alarming. I will tell you why it's alarming, because if you look at the global risk to humanity, or to all of us, this is from the World Economic Forum Global Risk Report, and it's a perception survey, right, asking people. You will see that in the next 2 years, what people worry most about is misinformation and disinformation. And you know that WHO even called this infodemic, you remember, an epidemic of misinformation, particularly during the COVID pandemic, and all sorts of things were being spread, particularly through social media. And this has detrimental effects to many things, not just in terms of health, but also other things as well, economy, politics, and so forth. Now, extreme weather events are number 2, and this is where I will also focus on a little bit more. But if you look at the next 10 years, you will see this list is almost turned upside down. You will see that, for example, economic weather events, changes to Earth systems, what I mentioned in the planetary boundaries, biodiversity loss also in the planetary boundaries, natural resource shortages also in the planetary boundaries are all going to be the number 1 risk. Now, how does that relate then? So you will see that our current risk landscape is dominated by environmental risks, and this is something we have to think about a lot. And as health professionals, as a health community, why is this important? Because the United Nations Development Programme in 2022 came out with their Human Development Report, and what it showed, for the first time, all countries in the world showed a decline, almost all countries in the world showed a decline in our health indicators. And partly from COVID, but also it seems to be persisting. Now, every day we face uncertainty in life. For people who are poor, uncertainty whether they'll be able to feed their family, for people in conflict, whether they will survive the night. And for us, maybe the uncertainty of whether there will be horrible traffic going home, or whether there's going to be heavy rain or flash floods, right? But there are three other very, very big uncertainties that lead us to live now in what is called an uncertainty complex. And the first is the dangerous planetary change of the Anthropocene, what I mentioned earlier at the start of my intervention. The second is pursuit of sweeping societal transformations, things happening, suddenly, things change, but the rate at which it changes is amazing. Conflict, first in Ukraine, then in Gaza, and all sorts of other challenges we face. Widespread, intensifying polarization, racism, a lot of issues, geopolitical tensions, and so forth. So I always remind everyone, especially health personnel, because sometimes we don't realize that the determinants of health are not entirely in the health complex, as wonderfully shown by the previous presentations. It is about social and environmental factors, tobacco, alcohol, our diet. It is also, a result of behaviors, what we eat, how we choose to live, and also environmental factors, which are extremely important. So 75% of the determinants of health are outside the medical care complex. And I think this is something very important to remind ourselves, because I think sometimes when we are educated in medical school, we're not taught this, right? We tend to be very clinical in our approach to medicine, whereas we realize that, that this is why public health is very important. There are many other factors that determine whether we are healthy or not. The little chart on the right is a little bit of work I did in Malaysia, looking at, what interventions actually will cause better health outcomes. And it really is the prevention and promotion and environmental and social and behavioral interventions, which will account for 67% better outcomes rather than therapeutic interventions. So planetary health emerged because doctors like myself, many other public health physicians, came together to say it's not enough to just look at public health. We've missed a big component of one of the drivers of health, that is environment and the planet's health and biodiversity loss, because all that has implications on our food systems, on water and other things. So it's really a framework, a way of working, a way of thinking that addresses the interconnectedness of people and the planet and the growing anthropogenic nature of disasters that will impact our health and our survival. So really, this very important piece of work, that was part of the Lancet Commission on Health in the Age of the Anthropocene, led to a movement of planetary health. I'm part of that movement. The headquarters of the Planetary Health Alliance is based at Johns Hopkins University. Now, this is a very interesting representation. I'll walk you through it very, very quickly. I talked a lot about the planetary boundaries, what will happen, and so forth. And you look at the climate hazards, right? How does that impact health? And, if you look at wildfires, why do wildfires happen? Or you look at heat waves that lead to droughts, that lead to wildfires. But the landscape change that is related to that is really about deforestation, desertification, it's getting drier, reduced water availability, soil degradation. And similarly, if you look at storms and seawater level rise and floods, all those, there are health determinants as well. I know that Associate Professor will talk about particulate matter and pollution, so I won't delve on that. But increased temperature, water scarcity, poor hygiene, so for all these are health determinants. But the health outcomes are quite stark. Respiratory disease as a result of pollution, cardiovascular disease as well, infectious diseases, malnutrition, heat-related diseases. And underpinning on all this is mental health. I think we don't talk enough about the stresses to mental health, particularly from climate change. Climate anxiety is now getting to be really quite a serious problem. In lots of research being done with young people, a lot of them saying we don't want to have children, we're depressed, we don't think the world is a good place to live for young people. If you have time, there's a wonderful book called Generation Dread, written by Dr. Britt Ray from Stanford, which addresses young people's challenges with climate change. So disasters itself, we're seeing more flash floods, we're seeing more heat waves, all sorts of other disasters. All this have direct implications on health, and whether it's floods in the Middle East, flash floods which never really happened before, and even in my country, Malaysia, we are seeing a lot more floods happening more than before, and of course droughts in sub-Saharan Africa. This is a major problem when it does affect food production, nutrition, and so on and so forth. So, infectious diseases. We know, for example, right now we have challenges with tropical diseases moving to cooler climates. You are seeing dengue now in the US, you're seeing malaria, we're seeing new forms of climate-sensitive malaria. We're also knowing that the glacial melts that are happening are releasing thousands of microbes. We have no idea what kind of diseases will come in the future. But let's also look at the immense strain on global healthcare systems. It will lead to 14.5 million deaths and 12.5 trillion economic losses by 2050. Now, heat waves itself will lead to 7.1 trillion of estimated economic loss, and as well as flooding will cause more than 8 million deaths. These are what we call the 10 must-haves. What do we have to do to make sure that we try to put in some kind of control so that we don't exceed 1.5 degrees, so we don't go into this spiral of climate change and health pressures? And these are 10 things that have come up by a group of people led by Arizona State University, Johan Rockström, and so forth, and I'm also involved in this. And if you look at it carefully, what it requires is good governance at national, local, global governance. And until and unless we have those shifts in governance, it's important. And this is why planetary health is a multi-systems shift approach, which means we have to change our behaviors, our mindset, to make sure that we break those silos in health and look at how economic, social, behavioral, environmental factors must now be brought together to determine the outcomes in health for humanity. I end with this quote from Tedros and colleagues. These are part of the COP28 outcomes. For the first time, we've had 28 COPs. And for the first time last year, health was included. It's a huge achievement to be able to put health on the table, but very, very late. And as Tedros mentioned, climate change is one of our biggest health threats, and humanity faces a staggering toll unless we act. So I'm going to just end with, again, showing that we will be having a meeting in Malaysia 16 to 19th April. It's a global meeting. We have some scholarships for low, middle-income countries, so if you're interested, please look it up. It's a wonderful opportunity. We're bringing in private sector, government, civil society, academics, researchers, and the health fraternity to really look at, okay, we know the evidence now, how do we act? And I think we don't have much time. We have to stop talking just about the facts and the evidence. We have an emergency in our hands. We need to act. Thank you very much.
Thank you so much for your insightful lecture on planetary health, which is the more broader scope. So many diseases will be affected by this Anthropocene, so it will be a real threat, and we should prepare. And there should be many actions for this in the future. Because due to time limit, so the Professor Jelim Jo, could you talk on the brief summary for this session and your remarks or your comments.
Okay, thank you, Professor Shin. Thank you, professors, for your informative and insightful presentations. I could get some insights into specific health problems in South Korea we are facing. And this session is very interesting to me because I have done a study to estimate burden of mental health problems in children and adolescents in South Korea attributable to air pollution. So we've done a study regarding the burden of mental health problems and attributable to air pollution, and we calculated population attributable reflection. The level was about 10%, which means that if we reduce air pollution levels below the WHO's guideline, then we can prevent 10% of mental health problems, including ADHD, autism, and depression in children and adolescents. This is very, I think this level is very striking. I think this is not small. Yeah, this study is under review. And actually, I have a little bit of question, and do we have time? Okay.
Yes, you can.
Yeah.
One question.
I think it is getting more difficult to not just estimate, predict disease burden because of various unexpected global health crises, including COVID-19, global pandemic, and climate change as well. So I could get some advice from professors and experts about how we can deal with this uncertainty to predict disease burden.
Professor Mosen or Professor Laura, could you answer?
Sorry, say that again, your question, maybe I lost.
Oh, okay.
I think you raised a really important point, and thank you for sharing that research. I would love to follow up with you on this, because I think air pollution, WHO estimates about 8 million premature deaths per year from air pollution, and it's fascinating that you're sharing this data on children, because it's also leading to all sorts of things, including Alzheimer's disease, as well as infertility. Now, your question on the uncertainty and therefore what kind of diseases will happen, I think what was shared by our friends from IHME is so critical. You will see that many of those leading causes of deaths are actually behavioral in nature, and that, until and unless we get to the neuroscience, and this is my self-criticism as a medical doctor as well, because our education in health has not moved forward in a rapidly changing world. How many of you in this audience are actually doctors or medical students? No? Okay, never
Some.
mind. Yeah. Well, I graduated in 1986 as a medical doctor, right? And I knew a little bit about greenhouse gases. I studied public health, but there was no mention on climate change. And in 1986, we already knew. Carl Sagan and others had already started talking about it. This is 2024. And only 15% of medical schools still have any mention on climate change. So how do you talk to your patients? How do you change behaviors when you yourself are not educated? And that, 5% of global greenhouse gas emissions are from the health sector. So I'll give you an example. In UK, north of UK, they call it social prescribing, where instead of giving hypertensive medicine, they start talking to the patients to say, I'm going to give you a week of medical leave for you to start doing more walking. Go into the dales and walk, so that you start triggering behavioral change and not just a drug therapy as well. I say this because I think for us to be prepared for the future burden of disease, we need to change the way we look at health and the way we look at how we treat people, because behavioral change is so difficult. you know, it's easy to dispense drugs. It's so hard to get people to change how they behave. So ultimately, if you're talking about the uncertainty, unless every single one of us change the way we consume, the way we live, the way we react with our environment, the way our economic development happens, then we will see the burden of disease changing very rapidly.
Thank you for this great discussion.
I want to add 2 points to this discussion. Unfortunately, we are talking about 7 billion people or 8 billion people. These 7 billion or 8 billion people cannot give this type of advice that instead of the treatment of the hypertension, you should go 1 month for walking or 1 week. We have something in front of us that is situation that we have to survive in this situation and the situation that will happen. Everything that will happen is not only our task, but is most important is task of the government. We have to rely to the government, not rely to the poor people that they cannot treat themselves with the blood pressure treatment. This is big problem. We have to look to this process very realistic. We have our situation that is worse and worse, and the situation that we will have that maybe will be worse than now. But we cannot bring solution for the next year after 10 years to this year. I need now. I need now to fix my hypertension. Then please be careful. Uncertainty that we calculate around the disease is for this year, for the past, not for the future in the burden of disease. But in the forecasting, they have their own uncertainty that comes from the different scenario that they are using and different estimation that they are doing. Please be careful about this type of discussion. Task of future, problem of future, we have to start now, but by the governments. $billion government produce carbon monoxide and send to the air. Yeah. This is not a problem of the poor people or our patient in the clinic. This is problem of the government and people that make money from this carbon monoxide that they send to the sky. Thank you so much.
Thank you so much for your comments. Because time is over, so we should close this session. And thank you so much for the speakers and panelists and attendants. Thank you. Have a great day.
Thank you. Bye.
Okay, so thank you for the inspiring session. It was a great, enthusiastic discussion. We'll take I'll say a 7-minute break, and we'll return at 10:55, which is 5 minutes after what we originally scheduled for. Thank you.